Hello, friends. Hope all of you are doing well. Today, we'll be taking the Vital Pulp Therapy series part 5 discussion. We've done the first 4 videos of the Vital Pulp Therapy series. I hope you like them. Now, friends, today's discussion pertains to the choice of the wound dressing material, right? Uh, Traditionally, we have been using calcium hydroxide, but presently, since the past few years now, calcium silicate based cements have shown better results. And the most tested material out of all the calcium silicate based cements is, as you all know, mineral trioxide aggregate, commonly referred to as MTA. Okay, so today we will be discussing about what should be the material that should be used to cap the pulp or used as a wound dressing material. What is the wound? It is the when we've removed the superficial layers of irreversibly inflamed or degenerating pulp and we're trying to preserve the underlying healthy pulp, then what is that dressing material that we place over it so that that pulp remains healthy? That material has to be very biocompatible. It has to have the ability to stimulate the formation of a dentinal bridge, of a tertiary dentinal bridge known as reparative dentine, right? The better the quality of that, the better is the material, and that material we would prefer, right? And over that, we restore the material, we restore the tooth, right? So before discussing this material of choice, let us just have a brief overview of what all we've discussed till now in vital pulp therapy procedures. As you can see on the slide here, the various vital pulp therapy procedures are primarily 5 types. You have your indirect pulp cap, then direct pulp cap, then partial pulpotomy, full pulpotomy, and deep pulpotomy. Now, friends, this is basically nothing but you know uh, sequentially going deeper inside and exploring and trying to reach the correct plane, the plane wherein we have ensured that all the irreversibly damaged and or degenerating pulp has been completely resected or amputated, and what we are preserving is a healthy pulp which has intact its all the functions that a normal healthy pulp should do. One of the most important ones is the formative capacity of the pulp to keep on forming the dentine, the dentinal portion of the root, so that root end formation takes place and the thickness of the dentinal wall takes place, it keeps on increasing. Okay, now friends, if we just slightly, very briefly recap again, we are primarily dealing, see, all this pain that we are taking is mainly because of situations in which we are dealing with either traumatic exposures or carious exposures of immature permanent teeth. Otherwise, if you have a mature permanent tooth, the pulp is vital at that present point of time, irrespective, even if it is irreversible pulpitis, you do a pulpectomy, you have got very good results. Why? Because the vital pulp is still sterile. Even if there is some bacteremia or bacteria present, they're only present in the superficial layers of the pulp wherein there is carious exposure has taken place. So the predictability of the treatment of a vital pulp, even if it is irreversibly damaged, if you are doing a root canal treatment, that is pulpectomy, is very high. So all this pain that we are taking, all this case selection that we are doing, whether we should go for partial pulpotomy, whether we should go for full pulpotomy, what is deep pulpotomy, will a direct pulp cap be okay in this situation or not, all this dilemma that we are going through is mainly because of case selection in cases where we are dealing with what? With immature permanent tooth, wherein we want the root end maturation to take place naturally. That is apexogenesis to take place. That is why we keep on, going deeper and deeper inside the pulp to ensure that we have removed the irreversibly inflamed pulp. Okay. Now, friends, we've done so. We've reached a plane whether the patient after a traumatic injury has come to us, and we have reached the plane by doing a partial pulpotomy, by only removing the superficial 2 to 3 mm. Okay, fine. Okay. What about we've not reached that plane of the healthy pulp? We go for full pulpotomy. Still, we have not reached. We go for deep pulpotomy. Now the question is now, we've done this, the case selection is fine, we've determined and we have documented and we've done the procedure. We are bang on with the procedure that we want to do. Now the question is, what should be the wound dressing material? Whether it should be the traditional calcium hydroxide or it should be the newer calcium silicate based cement like MTA. That is the question. Now, beyond doubt, it has been many years now, and beyond doubt, it has been shown that MTA is a better material than calcium hydroxide, primarily because of many reasons, but primarily because of that one particular reason, that is the quality of the reparative dentine formed is much, much better with calcium silicate based cements like MTA. So, for the majority, for all these vital pulp therapy procedures, go for MTA or go for any other calcium silicate based cement like biodentine. In general, MTA is mentioned everywhere in our textbooks. Why? Because it is the oldest of the calcium silicate based cements. It has got, the most studies have been done, evidence-based research has been done with MTA. Okay. So it is now beyond doubt that the better material is MTA. So the material of choice, because of the fact that the quality of reparative dentine that is formed is better with MTA. Okay, so that becomes the material of choice for us. So that becomes a material of choice for IPC, fine, DPC, fine, partial pulpotomy, fine, full pulpotomy, fine. But there is one more situation that is left. That is deep pulpotomy. And in deep pulpotomy, the material of choice is calcium hydroxide and not MTA. I repeat again, friends, for deep pulpotomy, the material of choice is calcium hydroxide and not MTA. Now, let us see what is the reason behind it. As you can see here in this diagram, I'll just show it to you. Please, friends, just see this. In deep pulpotomy, what do? We actually go inside the canal up to some distance inside the canal. Why? Because even when we were doing a full pulpotomy right up to the CJ, we could realize that our pulp was irreversibly inflamed. What do? Our case is that of an open apex. We have to do all our efforts to preserve the vitality of the apical stump of the pulp and hope that it is not irreversibly damaged. Right? So we go deeper inside the pulp. Now we've gone deeper inside the pulp and resected the pulp at this level. Okay. And now we have to give a wound dressing material and restore the tooth. Now, because we've taken this chance, and there is a very high chance that this tooth might just become necrotic, that the apical pulp stump will also not survive. Then what will we have to do? We will have to go for a root canal treatment. But if we seal this with a hard setting material like MTA inside the canal, you all know that the retrieval of MTA is very tough, whereas calcium hydroxide is water soluble. Therefore, in cases of deep pulpotomy, calcium hydroxide is the material of choice. All right, friends. So I hope this very important point has come across to you and you've understood this. And in any MCQ or any Viva question, somebody asks you all the first 4 procedures, material of choice, MTA, or any other modern calcium silicate based cement like biodentine. But for deep pulpotomy, the material of choice is calcium hydroxide. That should be it for today. Thank you for listening.